This is Vernal. Can you see and hear us? I'm assuming you can.
Well, don't speak up at one time.
Can you hear us?
Can you hear us?
Yes, ma'am.
We can, thanks.
Great, thank you.
So yeah, usually I'm a breakfast person. I usually always eat, but I did the same thing you did. I was like, oh, I'm kind of rushing this morning, but I don't need to worry because
If this was a small storm,
This is Reynolds, right?
Oh, everything got quiet. We're not quite ready to start.
that awkward silence. Surprised me. Okay, so we're looking at Wednesday. Monday snow.
Yeah, nothing. Chatted.
Oh,
She's on.
Letting out like 2 o'clock in the morning. I couldn't get him in. He loves the snow. I call him and he looks at me. I went, okay, I'm closing the door for a few more minutes. Finally, what I had to do, I had to take a bag of food.
is she calling on that one? Sweet.
I think he's trotting, think he's going to get a treat.
I don't know.
When you say Bernie, I see the cute little eyes in his.
Can say something.
Creep. 9-foot-1 paws everywhere.
Hilda.
It's like a little
They count. 2 days later, now that we got the caretaker. So,
J at utah.gov
Is it for the? Is it
James
for
Mason
the?
on what we do.
hold off on a small bet. It should be Hilda BJ.
So she doesn't come. She's not gonna come.
I won't be here today. J at utah.gov.
They just.
That is in trying to put that all in one big value. It's hard, like you guys said.
Do you have Cynthia?
I just
Yes, that's right.
she thinks it's a good idea, and I'll have to ask her again because I don't know if she.
Do you have Cynthia on there?
I go to the physician meetings.
And Natalie Allen.
For the first part of it.
Who is our nurse practitioner?
Discuss it.
She oftentimes
Because
does.
like I think the last time we talked, we were like,
I need to talk to her again and see if she reached out. Because you're always carrying luggage every time I see you.
what do you have for Cynthia?
but it's too much stuff.
I know. It's just those ones that
Is our little patient still at South Davis?
yes, and the movie type stuff, which we have some doctors that don't touch it.
When I first started with state, they gave me first initial first name,
So it's a little
I would say Chris because it sounds like religious.
through the door with them. So something
Evolution is great here.
until you
Every time I put it in, I would think, lightning is going to come.
I'll give you free
Well, she hasn't been with her dad ever since we went to South Davis, but that's her plan to go out with her dad.
I'm going to run.
I said, so what did it will you
Get a
like?
snack.
I haven't talked to him yet. I'm like,
No, let's just.
I actually went and had her talk with South Davis, the three of us. Oh, good. So Kevin's like, I think
I thought about
ticket.
like talking today.
I'm gonna highly discourage. He's very sick, but he's on a bit full time.
I saw that he went to the UCCCN. They had him on the bed.
And RSV.
Yeah.
Yeah, and he's never gotten up from it.
I also reached out to
So I don't know if that's gonna throw a hitch in. They're like, I'm going in there. It'll be a
Yeah.
fight. I think it was
It is crazy, y'all. Yeah.
She's from up north. And I don't know that she's international. I feel like maybe one of those, but I don't recall off the top of my head. There we go. Great. Super. Linnea. All right, well, let's give it one more minute and let's get started.
It seems like no great idea.
Sure. Okay. Right. Okay, do you want to turn the sound on?
And I just want Laura to know that check should be forthcoming.
All right, I think we'll go ahead and get started.
Just start. But it seems that they
Good morning, everyone. I'm glad to see you here. I was really excited to see several people start trickling in pretty early and then not so many. So maybe the weather is affecting some folks joining, and maybe we'll see more on GoToMeeting this morning. But let's go ahead and get started. Let's switch to this screen and go over our agenda really quickly. So we'll start with some introductions, as we usually do, and then a few little housekeeping things. And then we will talk about any cases that you'd like to discuss, anything else that you'd like to bring up. So new resources you might be aware of, any wins, any barriers that you feel like you're facing that maybe we can kind of crowdsource. So that's your time. And then I do anticipate that our two presenters today will show up right around 9. So if we get through the brainstorming part a little bit quick, we'll have more time to eat. And we got a lot of carbs today, so carb up. It's great on a cold, snowy day. And then we'll try and wrap up right promptly at 10. And let's move into our introductions. I was hoping to see someone on our vernal feed, and perhaps the weather has affected him. That's Wes, so maybe he'll be able to join us a little bit later. My name is Mindy Tueller, and I manage the Medical Home Portal, and I facilitate this meeting. I think most of you know me, and then I'll go ahead and take a look at the folks who are on GoToMeeting, and for those who have typed into the chat box, I'll read their names. So we've got Walt Torres from Integrated Services. Hey, Walt. We've got Linnea Bauer from the Medical Home Portal staff. Good morning, Linnea. Tammy Brandon, Nurse Care Manager from Northern Utah Pediatrics at McKay-Dee Hospital. Good morning, Tammy. And we have a few more, and we'll let them go ahead and type in as they're able. Also, just a quick aside, and I've got this on another slide, but for anyone who calls in to GoToMeeting, and if you're calling in only and not also getting on via the computer, we often only see you as a caller, so we don't know who you are, and it would be so helpful if there was a way for you to let us know who you are by maybe sending a quick email to me to just let me know, and that's for reporting purposes so that we have a more accurate understanding of who's attending. Great. Okay, so let's go ahead and go through the room. So, Gabby, do you want to start?
Yeah, so my name is Gabby Baragoshi. I'm a quality improvement specialist at UPIC and also helping out at the UCCCN meetings.
I'm Pat Rowe, pediatric nurse.
Sorry. I also have Dawn Bentley on the phone or online, and she's also a quality improvement specialist, also helping at the UCCCN meetings.
That's right. Sorry, Dawn.
I'm Pat. I'm a PEDS nurse care manager for Select Health Insurance.
And I'm Heidi Bates. I'm the PEDS nurse manager for Redwood, and then I help with the community clinics out there.
I'm Corinne Romero. I'm the community care manager for Primary Coast, the connector service.
I'm Carly Falls. I'm a care guide at Southridge Pediatrics.
I'm Jan Boker. I'm a care manager at Memorial Pediatrics.
Cicely Tillman, nurse care manager at Memorial Pediatrics. I'm Heather Castor. I'm the care coordinator for Wasatch Pediatrics Draper office.
Greg Hawks with James Mason Centers for Recovery. I do the marketing and community outreach.
Suanna Jeffers. I work for University Health Plans. I'm a pediatric care coordinator.
Mary Martinez, a care coordinator for Integrated Services Program Department.
Hi, Eric Christensen with Utah Department of Health Integrated Services.
Gina Money, Utah Parent Center and Utah Family Voices.
Kay Haynes with the resources on the medical home portal.
Kim Perry, I work at Southwest Children's Clinic and I'm the care coordinator there.
Great. Terrific. All right. I feel like maybe a few more people may have joined.
Richard?
Yeah, we've got several people who have joined on GoToMeeting. So,
Richard, if you want to introduce yourself, please, go ahead.
Looks like she's muted.
Amy, if you want to introduce yourself, that would be great. Or you can come up in the chat box. Then we also have McKenna. And Stephenson.
Neva. She's from Shriners. Great. All right, well, I think some folks may not have the ability to talk, to unmute, so that's fine. All right, let's go ahead and get started. And great, Allison Lewis just arrived. Okay. So just a little bit of housekeeping. For those of you who are here physically with us, the bathrooms are just down the hall, just kind of opposite those main east doors that you may have come in. And if you need Wi-Fi, it's the Blue Zone network here. There's a guest option there. As I mentioned before, if you've called in to GoToMeeting but you don't have a computer connection as well, we don't know who you are, and so it'd be terrific if you wouldn't mind just shooting me an email to say, hey, I was on the January 16th GoToMeeting call, and that would be super helpful. And then as you guys know, we need to end promptly at 9:59 when our recording goes boop. But without anyone on the other end, it's not quite as a big a deal today. All right, so just a few announcements. For those of you who had not yet responded to this and maybe were a newer member to UCCCN, an email was sent last week asking you to answer some questions and opt into a shared directory, which is just basically a Google document that we only allow access to those who have allowed us. And that way you and anyone else who said yes have access to contact information from others in the group. And that way we don't just let everybody contact everybody. We do it with your okay. And so for those of you who responded to that, you'll have access to that Google document very shortly, maybe even later today.
Next week.
Next week. Okay. Very soon. And then I wanted to point out, for those of you who may have noticed or even participated, that Allison Lewis, who is, I think, on GoToMeeting with us, put out a call for help. I think it was just last week, and people really rallied. So that was super exciting, and I think it was fantastic. I'm not sure what the best way to do that is. So it's great to see all the responses, but at the same time, some people may not want more email if they're not able to be a part of that. So I was really enthused to see all those responses, and I know there were actually even more than those because I chatted with Allison about what she had learned, and she definitely got some things that should help her to get that family moving in a different direction, I think. But I think the bottom line is that's what this is all about, is helping one another. So I thought that was terrific. We've toyed with the idea of doing something more along the lines of a closed Facebook group that would permit that kind of back and forth in more real time. We would need to moderate it, but it could be done, fairly real time, I think, certainly during business hours. I don't know if that's something that people would be interested in. Facebook is an existing platform that many of us already are on, so we could leverage that. At one point in the past, we tried to create a forum using some software and asking people to get on and try it, and it went nowhere. And it was a little clunky, and it was one more thing that you had to log on to and all that kind of stuff. And so we recognized that that's just not going to work. We need to take advantage of something that's already in place and people are comfortable with. So this is a very unscientific poll, but for those of you in the room, and if you're able to show on GoToMeeting, we'd love to get your feedback as well. Would you be interested, and do you think you might use a closed Facebook group for UCCCN where you could put questions like Allison had out in between meetings, or respond to questions like Allison's?
So Allison writes, very interested in Facebook group, and Tammy said, wouldn't get on Facebook at work.
Okay, so that's the concern. So yeah,
I know Facebook is there's a behavioral health network on Facebook that I've been a part of that actually has been very well used, awesome.
Right, you mentioned that.
And so it has worked a lot.
Mm-hmm.
So I am all for more connection.
Okay.
That way. So I would definitely be a part of it.
Okay. So yeah, we might try and pursue a little bit more feedback on that. It would be a significant. It's not something we should take lightly. So once we move that direction, we got to commit to that moderation part of it. Understand all the rules that kind of go along with that. So we've done a little bit of investigation, but we could think about doing that more. But I really appreciate all of those who wanted to put out some help for Allison. So I think that's just terrific. Okay, so I think that our presenters might be outside, and I don't want them to stay out there, so I'm going to tell them this is a very informal group, and they can come inside. Hi, are you guys? Dinah, come in. We're very informal here. It's no big deal. Just come in. Oh, it's fine. It's just for archival purposes. It's no big whoop. So, okay, great. Okay, so I wanted to mention some medical home portal updates as we try and let you know. So we're pretty excited that we have a new module. So I'll actually go to that real quick. So we had been wanting to get a cystic fibrosis module for quite a long time. We had some of it done. Then our author had some issues, and so it kind of sat for a little while. And then we have a partner state, New Mexico, with some stakeholders there who were very interested, and they pushed us and actually helped us get some authors and some experts involved. And so finally, here it is. So we just want to make sure that you are aware of our latest full diagnosis module, which is cystic fibrosis. And while I'm showing you this, I might point out that we've made some changes in the navigation, so that now you can see all of those subsections under each of our top sections in a diagnosis module. So we can collapse this if you want to just kind of have that short view, which is what you used to only be able to see. And then if you'd like to see more, you can either just open that section that you're interested in and close it, or you can expand everything. So hopefully more quickly you'd be able to see what you're looking for. So if you're interested in the endocrine issues for someone with cystic fibrosis, you could go more quickly right to that section. So yeah, we hope that will be useful for any of you who might be helping or know of someone with cystic fibrosis. Let's go back to our PowerPoint. And if you guys want to just come and have a seat, again, we're very informal here. We get up and grab food and move around anytime, so no big deal. And then the other thing I wanted to let you guys know that's relatively new on the portal, it's been around for a little while, but I'm not sure that we've totally pointed it out to folks, but it may be of use to you. So if you happen to be looking for a service provider in, let's go to Utah, the Utah Services Directory, and you either see that there's a lack of the service provider that you know exists, and you would like to help let us know that it should be in our directory, or you, for instance, you see something and say, oh, that's not right. There's something missing about that particular record. And I am not this is maybe not a good example, but let's take Christmas Box House in Ogden, for instance. Maybe there's some information here that's not quite correct. You can let us know by simply clicking this little link right here. It says suggest and edit. I hope people can see that. Suggest and edit, and if you click that, you'll have this little pop-up box where anything that has an asterisk is what we really need you to let us know. And make sure that something's filled in there. But otherwise, you can suggest any changes, and you can tell us a little bit more about why you think that needs to change. And if we see that it's you, a UCCCN member, then that lets us even act a little bit more quickly to try and follow up on this because you're a trusted source. So we would love you to use our suggest and edit, or if we go back to kind of our main service directory page, suggest a new provider. So none of the fields are pre-filled here. That would be so great. That will help us, again, to crowdsource our services directory, keep it more up to date, and keep it, more fully complete. So we'd love to have your input there. And Linnea says they can use the notes box to mention that they're with UCCCN. Yep, definitely. Great. All right. And then we have continuing projects having to do with improving our list feature, improving service category information, and also improving search. So just letting you know that those things continue to happen. All right, so this is when we turn the time over to you. If there's anything that you'd like to talk about, we were just mentioning Allison's case. I don't know if there might be a possible update on that. It's a little soon maybe, but we'd love to hear follow-ups on previous cases too, hopefully positive developments in those. Really anything that you would like to share with your colleagues, this is your time. So is there anything anyone would like to mention? Yeah.
So it's not a case, but we are looking to hire a therapist.
Okay.
So if anyone knows of anyone who's interested in a therapist who would like to work with teens and, through doing groups and individual therapy, stuff like that, they need to be a master's level therapist or higher.
Okay.
Just let them know that we are looking to hire. So pass them along to me.
All right. Will do. Yeah, Carrie.
I have a case. He's a 17-year-old boy with severe autism, nonverbal. He is in a foster home, and he has been okayed to do like a Friday night out in the community work with assistants who are trained in the safety care program protocol because he sometimes can get violent. They've been approved for 2 employees to do this with them, but they're having a hard time hiring. So I was wondering if anybody knew any sources out there where they have people who are interested in doing this kind of work.
And so where does the training happen? How does that happen?
Once they're employed, they'd go through that training, the safety care training for like safe restraining and safe redirection and all those type of things. They're just looking to hire qualified people to.
So this is the family.
This is a foster care. It's a child who's in foster care. And the program is, he's in an after-school program with RISE, but the program for work is like they're trying to get that going. He's been approved to do this in the community for 4 hours, so I don't know of any. I mean, other than job boards and students and things like that, I don't have any other suggestions, but I didn't know if you guys had.
Do you know, like, how long the training is and what the person could expect to get paid?
Oh, I'm sure it's like minimum wage. And the training, I don't know how long it would take, but if it's similar to like other trainings, it would be on the job and then a certification, maybe a Saturday.
Okay, so pretty quick.
Yeah.
They're not.
Yeah. And they would never be like, oh, goodbye, you're on your own. There's always going to be 2 people. So.
And they would accompany this person to their
For
job.
that 4-hour training.
Is it the training comes through DCFS or?
That I'm not sure who the training is going to be through. I mean, he's in the foster care. He goes to the Karisu program during the day. He does Rise. I mean, they've got him involved in everything they should have him involved in. They just need these employees to go with him into the community.
I just know, so our neighborhood has one of those social network things called Nextdoor.
Yeah.
And I see requests for things that would be sort of along this line all the time.
All the time.
And it's interesting because it really does connect people. It also lets people complain a great deal about their things in their neighborhood, but it has some positive things as well. So I don't know if that might be something if someone's on Nextdoor and they could put that out there, but I see that quite a bit. So.
You think DCFS should have some kind of posting? You know.
No.
No.
Maybe not.
I'm just wondering, is it Boca Rehab?
You would think.
So actually, who would actually be responsible for the training?
No responsibility.
Yeah, there's no connecting all those dots. It doesn't sound like.
So there's got to be some sort of a supervising organization that's doing that. So I'm just wondering, is it Boca Rehab, or do you have somebody
Right.
along those lines that might be doing that?
Yeah. That's a tough one.
Yeah, it's kind of hard.
Yeah. Well, let us know.
Learn.
Yeah.
Yeah. Okay.
Yeah. Okay. And if we think of anything, folks, let Carrie know. Any ideas?
Yes.
Okay. Anyone else?
So
No, please go ahead, and then I'll.
So mine's a little bit on the same lines as that, but maybe just a teeny bit different. So I have a little cute little girl that's graduating from high school. So she's in the transition period. So she's a doll. She's pretty high functioning autistic. So she can carry on a conversation with you, understands what you're saying. She's partially blind. So she's blind in one eye, but she's got the cutest personality ever. And so her mom is looking for a couple different things. One, kind of like a day treatment program after school that can keep her engaged and, give her activities to do and stuff. But then she's also wanting to get her started on getting a job. So she was thinking maybe like a greeter or something that's a little bit more social for her, since she's so cute and, can function pretty well. So I don't know if I haven't had any luck, and I've only been doing this for 6 months. So I'm sure some of you might have a lot more resources than I do. I've looked on our website. I've tried to research and find a particular place that takes children who are in transition like that can keep them occupied and keep them engaged for the day, and then transition her into finding a little job for her to do. So I'm open to any suggestions if anybody has any after that they can give me. So that one's kind of a hard one for me. Huh?
So she's currently going to school.
She is currently in school. She's graduating. Yes.
Okay.
So she wants something after she graduates this spring. So that's one. And then I have one other little guy that I've been following, that I've been very engaged with, and very, I've been a big part of what he's been going through. He's 12. He has quite a few problems, mentally disabled. He does have drop seizures. They're getting better with his meds. G-tube, ADHD, autism, a bunch of stuff. So he has some developmental delays for sure. But his physical therapy is not working as well as we would like. He's still getting really stiff. He is mobile with some help. He can walk, but he just gets really stiff. So we're looking for aqua therapy. But obviously I need someone or a center that can deal with someone of that caliber that has those disabilities. So if any of you know of any aqua training or aqua therapy I can get for him that will deal with disabilities like that, that would be wonderful.
On Saturdays, the University of Utah physical therapy students do a community free service for children that require well, and adults too, that require extra physical therapy that is not approved for, like through insurance or whatever. I'm wondering if somebody there would know, and if you want, I'll give you my contact information, and so you can email me and I can give you the specifics of that. But they do, it's just the students that are kind of giving back to the community that are
would be
in the
great.
physical therapy school.
And he goes to the comprehensive clinic, and he does PT up there with them, but it's just not quite enough for him. We need to get him in and see if we can get some water therapy, huh?
What area is he in?
So we're in Draper, and I believe Mom lives in, I think they live in like Kearns, West Jordan area.
Because the McKay-D Aquatic Orthopedic Center does therapeutic aquatherapy for children, and I can give you their number.
I wonder about Tosh.
Tosh does it. I don't know if they have
or
what their
specific
stricter
for kids.
criteria it might be, but
that
Tosh
would
does
be
do it.
closer
And
to
I
where
found
you're-
some, but they don't necessarily deal with disabilities.
So, a question for you. So, if they're out in the Kearns, West Jordan area, there's the Wasatch or the Ochre Park out there that's got the huge swimming pool complex out there. I didn't know if just through like community education or, community, swim or whatever, they might offer something like that.
Disability.
I'm not sure, but it might be a tree to bark up and see if you can.
Yeah, thanks.
If they're out
I'll
that way,
take
though, that huge
anything.
pool complex. My guess would be they would have some sort of. I know that my nephews go out there for some stuff.
So is it kind of like through the rec center there?
Yeah, rec center. That was the word I was looking for. Yes, rec center.
You would think there would
That sort of a
be
thing,
something
possibly.
through the county rec center. I know they had adaptive programs for kids, but I don't know about water sports.
Yeah, and I think I did look that up, but I didn't see any water. I didn't see any aqua therapy or water therapy.
Did you try the Sandy Rehab Center? I think they work with Tosh, and they're the aquatic Tosh. Yeah. From what I understand. Or Wasatch Adaptive Sports.
There's also a woman.
Regarding your first case,
Yes.
Richard says, check out YMCA. They have an after-school program for kids, and they may hire her to help.
Okay. Thank you.
There's also a woman, her name is Liz Egan, that has been doing aquatherapy for years for individuals with disabilities, and I'm trying to find where she is at the moment. I think she's in our portal someplace. But so I'll research that further to make sure she's still doing it, because she calls the center all the time and will let families know about her. But I want to make sure I'm not giving you somebody that's just retired, because as soon as we find the great resource, like
They're not there anymore. That happens.
and then for your cute young gal, has she been involved or referred to vocational rehabilitation? Because that would be a place where they can help placement as well.
For a job, yeah.
And her mother is just totally on it. Very organized. So, and she was telling me about CTA. She said that they're wonderful. I don't know a lot about them. And I asked her about DSPD if she had a caseworker, and they do, but I don't know if they're helping her very well with that. Or if they can. I don't know.
Well, actually, if she's involved with DSPD, they should be helping with the employment piece, because
That's what I was wondering. Okay.
So many employment pieces and transition pieces going on currently.
Okay.
So if they're on the wait list, it's a little bit more challenging, but that doesn't mean that there's not services available for employment.
Okay.
But I would, in school, the voc rehab counselors should have contacted them. But so many families fall through the cracks, so it might be worth just asking if they've had. Schools have now what's called pre-EDS, which is pre-employment training specialists or supports, and so they may have fallen through the cracks. So it might be just worth asking questions to see.
Okay.
Pre-EDS.
And does she go to the school for deaf and blind, or is she in?
I'm not sure what school she's in. I'm assuming
Yeah.
probably,
That
but
would be a good resource if she's not. Like, they may have information there for helping after school care and things like that.
oh, guys, thanks.
Cool. I'm sorry, Eric. I think, you want to do it super fast?
Well, I am so excited to hear from Dinah that I don't want to take. I was thrilled to see her this morning. So, but just really,
Happy to turn around and hear your voice.
just really quickly, I just wanted to throw this out here really fast. After months of a dearth of any sort of grant opportunities, within about 5 minutes of each other, and 2 grants that are due within 3 days of each other, out of Health Resources and Services Administration, the Maternal and Child Health Bureau. One grant that is due March 8th is Innovations in Care Coordination for Children and Youth with Autism Spectrum Disorders and Other Developmental Disabilities program. This one is really looking at kind of underserved areas, and they're looking at 2 big pieces. They're looking at family navigation, so parents who have experience with kids on the spectrum who can help coach and guide those families in. And then a provider education piece, so providing education and training and technical assistance to providers and community-based organizations on improving care for children with or at risk for autism spectrum disorder. So we're looking, I'm going to listen to one of those informational webinars on this one tomorrow to decide whether it's worth trying to take the plunge into that one. The one piece is it's family, they mentioned care coordination, but the big focus is family navigation. I initially thought, wow, I know a whole bunch of care coordinators. This might be a really good way to tie this all in. I'm not so sure on that one. The other one is called, it's Pediatric Mental Health Care Access Program. And the pieces that really jumped out to me is they're looking for mental health care telehealth access program. So they want a statewide or regional network of pediatric mental health care teams. And their definition of a mental health care team is psychiatry, LCSW or psychologist, and a care coordinator. Okay, so some organizations may already exist that way. And they want, one of the pieces that kind of made my skin crawl a little bit says they want to provide rapid statewide or regional clinical telephone or telehealth consultations when requested between the pediatric mental health care teams and pediatric primary care providers. What I didn't know is if that's a 24/7 sort of a thing or if that's during waking hours or whatever. So there are a few questions on this one, and I'll be listening to a conference on that. I just wanted you to be aware, though, that those are out there, and I may be reaching out at some point as we look for partners to kind of decide, if there are some of these practices, pediatric practices that have a really great, medical home model and that have maybe a psychologist on board or access to psychiatry, it might be worth tapping into some of those existing networks. Because as with all grant funding, they want you to keep the majority of it going after the funding goes away. And so both of these would really be looking at trying to get infrastructure in place so that providers have networks of, ways to refer into systems. And, systems that already exist certainly are more self-sustaining than when we try to create something new.
That's exciting. Great. Okay. Thank you for letting us know about that, and we'll watch for more. All right. Hey, with that, let's go ahead and have Dinah come on up. So this is Dinah Weldon, and she's the director of the Center for Safe and Healthy Families at Primary Children's, and she's going to talk with us a little bit today about some of the services that they offer. So ideally, you will have this semi near your mouth.
Okay.
Okay, so you can hold it, you can attach it if you want.
All right.
You can set it there and just stay like that.
I'll hold it. Hold that.
Sounds great.
And then
I can
video-wise, it needs to be here?
Oh, no. It follows you, and don't worry about that.
Okay, so as long as I have this near me? Okay.
Yeah, and I can forward the
That
slides
would
if
be
you'd
really
like.
helpful. Okay, thank you. First off, it was really inspiring getting to listen to you all talk today. I'm so grateful that you took that time to have them share their stories. I came from the state of Utah, Children's Mental Health Administrator. I had the great privilege of working with Gina and Eric in that role. And to sit and listen to you, I love my new job, but I have to tell you, you made me really homesick for my old one. So I know that I admire the advocacy that you're doing in behalf of the children that you serve. And I consider it a privilege to get to be here with you today. So very inspired, little choked up, not kidding when I say that. So want to talk to you today about Primary Children's Hospital Center for Safe and Healthy Families. And I don't know if I'm working too much with this. And okay, can you all hear me? Because I'm used to talking louder, but I have this here, and all of a sudden I feel like I need to be quiet, like I'm in church.
I just asked our people online, and they said yes, they can hear you.
Okay, great. All right. So, I'm trying to figure out what's going to be the best way.
Okay.
So, the Primary Children's Hospital has made a commitment to look after children that have experienced abuse and neglect. So there are different types of abuse and neglect that I've learned a lot about. I knew in the public sector a lot of what I would experience, but there are other elements that I didn't know. So let's just talk a little bit. The physical abuse, Primary Children's Hospital is a level 1 trauma center. And so when children, and that's the highest you can be. And so there are times that children will come in, and if they are coming in inpatient and there's suspected non-accidental trauma, we are absolutely contacted, or even if they're in the ED. We also, children experience neglect, and then sexual abuse and acute sexual assaults. The difference on that is going to be that the time frame. Both of them are traumatic, but one of them in the time frame of depending on their age and the type of assault that would happen, we have time and opportunity to make a medical difference in their lives. And we also have an opportunity to collect evidence. So if it's an adolescent and it's been within 5 days of contact, there are things that we can do, and we'll talk a little bit more about that. But that's why we differentiate between abuse, which can be historical or over long periods of time, and an acute sexual assault. There's also another concept of medical-related child abuse. And so it's 3 different areas: intentionally making a child sick, or overutilization, just requesting every single test and doctor shopping and switching. And those used to be referred to as Munchausen's by proxy, but we're focused on the effect of the child. And so that's why it's medical child abuse, medical overutilization, or there are times that there'll be medical neglect. There's life-saving treatment available. People are saying it will have a high likelihood of making experts, specialists, saying that it has a high likelihood of making the child heal and safe. And for some reason, the parent is choosing to use essential oils or something rather than getting treatment. And so sometimes there are things that and I don't mean to insult that. I wasn't trying to. I'm just saying there may be something very important that can save the life, and something that they may try not to, or they may choose not to engage at all. So medical neglect is the third one. Those are the 3 areas that we deal with. We see approximately 120 inpatient children a year. So that means the physical abuse is so significant that they required an inpatient hospitalization. We have an outpatient clinic that we staff. So if there's been if there's a call that comes in and we can see them, we will do same-day appointments. We'll do next-day appointments. And then we also have after-hour services that time frame we talked about in terms of an acute sexual assault. We will actually get up in the middle of the night, depending on the type of contact and when that contact happened, to be able to go in and provide medical treatment for the child. We also have 14 satellite locations, and you can see the volume of patients that we see across the state. We also have on 24-hour on-call, so a provider may be seeing something in their office and go, this looks like a grab mark on a non-mobile child. That's a sentinel event. That is a really big deal. You've left a bruise. And I'll hit the sentinel events now. Sentinel events are the type of events that if they happen, if you don't intervene, the next time you see the child, something far worse or death may result. So a bruise on a non-mobile child is a really big deal because they didn't get that from just crawling around and falling. And that means someone's frustrated enough with an infant to do that. So those are the type of things that if a pediatrician is in their office, they have a question, they can call and get a hold and get a consult, regardless of whether they're an Intermountain provider or not. We can help guide them and go, yeah, you probably need to do X, Y, and Z. And so we have a wonderful team that we try and partner all across the state and work with people all across the state in behalf of children. So I didn't know when I started there, yes, I'm interviewing for a job, and I learned that there is such a thing called a child abuse pediatrician. They're a pediatrician who then gets a 3-year fellowship learning about how injuries happen and what they look like and what things isn't child abuse. Our medical director got called to the emergency department in the middle of the night. You've got to come. This is the worst abuse we've ever seen. She goes in, walks in, and looks at it and goes, it's a rash. And so people just don't get used to seeing children genitalia, and so that they don't always know all the different things. And so our team gets really expert on being able to discern. No, yes, it could have happened. No, yes, okay, thank you, very logical. It could have happened this way. What the story is matching. This is possible. And so everybody back off, or I know it sounds really good, but there is no way the toddler did this to their sibling. So we have a really wise group, and there are 5 child abuse pediatricians in the state of Utah. They all work at the Center for Safe and Healthy Families. We're one of the national largest centers that have that service. We also are unique in the fact that we have the statewide services available. So we have in our satellite offices nurse practitioners and RNs and who can do these types of exams for us. We also have marvelous medical social workers, and Kari that's here with me today is one of those. And then she's also an LCSW, so we get a dual role there. And we provide at the Center for Safe and Healthy Families, we have therapy that helps the kids know something bad's happened, but it doesn't define you. And here are some tools that can help you move on and develop skills that'll help you have a wonderful life. And so that's one of the cool things about our program. We deal not only with the body, but we can help kids heal emotionally. Okay. So our main goal is the medical care, that we're going to diagnose and treat injuries, but then there are also, in terms of a sexual assault, there are times that there's infections. We can prevent sexually transmitted diseases if we can be brought into the situation soon enough. So I listed HIV up there as an example. If a youth has had an acute sexual assault and the type of contact and the high-risk situation, our medical staff may determine to provide this child with preventative HIV medication. It's a 28-day cycle. The thing is you need to get in there and start providing that service. 24 hours is better. 72 hours is your absolute final window. And if it's 73 hours, they won't prescribe it because by then the virus has escalated such. So for me, that was just, oh my goodness, we have an ability to make a life-altering, life-saving impact for a child that's experienced something horrible, and we can also do this for other sexually transmitted diseases. So I think that's one of the great services that are offered, and that's why we do the on-call 24-hour after-hours weekends. We have 128 hours that we cover. Then we also, as I mentioned before, there are just times that we can go, no, not abuse. There are times we go, we don't know. Could be, it couldn't be. These things say it could be. These things say it couldn't be. But there is that help to the community to be able to go, back off the ledge, people. We're okay. So the incidental purpose, while we're in there working on a child, having a child be safe, in terms of acute sexual assault that fits within that 5-day window, we will collect evidence. We will turn that evidence over to the State of Utah Crime Lab and help the family be able to track that rape kit. And but medical is our priority, and then we do the evidence collection as a secondary so that the child wouldn't have to experience a second exam. And I've already mentioned the emotional healing part, but I think for a child to be able to hear someone's trusting and believing them, that they're being heard, that there's someone who's going to help keep them safe, and that our medical team and our nurse practitioners can say to the child, your body's okay. Or if it's not, we're going to give you this medicine and we're going to help you to be okay. I think those things are very important for a child who's experienced abuse to know. Yes?
What resources do you provide for parents of these children who are as big a part of the family as any?
Absolutely.
How do they get counseling and how do they learn to cope with what's happened?
That's why we have medical social work. So our docs will be all, they'll deal with all the medical things, and then they'll turn to Kari or part of her team and go, help. So will you tell them just a little bit about medical social work and what you do for the families?
Yeah, so that's part of our clinic visit, and our clinic visit takes 2 to 3 hours. And parents will sometimes say, really, it's going to take that long? And it really does, because once they come in and they start talking, it's quite often the parent actually who's experiencing more distress, as you can imagine, than the child. Children are very resilient, or at least deal with trauma in a different way. And for a parent, they're basically living out their worst nightmare that something like this has happened to their child. And so we spend some time with the parent, calming them, reassuring them that they've done, they've done the best they could, because I think parents, again, feel like they should protect their children 24 hours a day. And then we sometimes even kind of in that moment do some calming exercises with them, if that would be helpful, and provide them a handout of how they can be most helpful for their child who's experienced a trauma, things they can do for themselves so that they can remain emotionally strong for their child. And then if they're in that state of mind, we do also talk about therapy at that point, so they can start to look forward for what can happen next and help them heal.
Now you know why I was so glad to have an opportunity to come to Safe and Healthy Families. Such a commitment and knowledge base. I love having that opportunity to be a part of this department, and wanted you to be aware of what the resources were. I'm just going to plow through real quick on the last couple things. It's a shared partnership. Primary Children's Hospital funds about $1.5 million of this service a year. It is something that is a commitment to the community through Intermountain Healthcare, but we also have a strong partnership with the Attorney General's office, and they help fund the satellite locations. And then the Children's Justice Centers, how many of you are familiar with what a Children's Justice Center is? Okay, so 14 of the 22 Children's Justice Centers in the state of Utah have our medical programs in them. It's a service provided by Primary Children's Hospital employees, and then we're working on adding 2 more, and I'm so excited. And then we also work very collaboratively with law enforcement and child welfare. So that's another big part of what we do. So a nurse practitioner and an RN is stationed in their local communities so that they can help provide these services. But there are times that just so you know, every report that they write is 100% peer reviewed. So our doctors or other nurse practitioners look at them depending on the level of what happened. So the quality of the information that's going out is really fabulous. And then that also, they may be called to testify in court if some of these cases are prosecuted. And we have brochures for all of you, and it will have a list of all our Children's Justice Center locations, as well as our location, how to gain access. And then I brought one other little gift for you. And this is this fabulous little, yes?
Do you guys have a forensic interviewer on staff? Is that
The
what
children's-
you use the child abuse pediatrician for? Or
It's a 2-prong approach. So our medical program, thank you, I'm so glad you know about we're trained in forensically sound medical interviewing techniques, but we are not doing the forensic interview. That's what the Children's Justice Centers will do. So even at Primary Children's Hospital, if we have someone come, then we refer them, we refer them to the Salt Lake Children's Justice Center in the Avenues. We're their medical program. And then the South Valley Children's Justice Center has the nurse practitioner as well as the forensic interviewers there. So they do the one-stop shop.
do they come up to the hospital and do it all at one spot?
No.
Or you do your medical intervention?
We do the
and
medical.
then send them
Ours
to the
tends to be the inpatient, the acute sexual assaults, or the Children's Justice Center refers them to our clinic. And so they've probably already gone there and then come there, but gone there and come to Primary Children's Hospital. But the reverse usually happens on the acute.
Okay.
They come in and then
And
we
you refer
link
them.
back. Mm-hmm. Any other questions? Great questions.
There's one on.
So last thing that I wanted to share is this little brochure is helping at, I'd say 8 and below. But if you have clients that you're working with intellectual disabilities, this is a great communication tool of how to talk to them about keeping their bodies safe and their how to say no and different things. So I love it. I think it's a fabulous tool. I take it to all my meetings. And after every meeting, I'm at with Intermountain. Okay, so who wants one of these? Got kids, grandkids, kids in your programs? And then there is a place on here on like the second page that you can order it. Okay. Yes.
So we have Tammy who's on GoToMeeting. She writes, occasionally we have a family call our clinic stating they are concerned their child was abused, sitter, etc.
Yes.
What is the best course of action for this? Should we call you? Send them to the ED?
Absolutely contact the Children's Justice Center in their local area, or if they're in this area, they can also call Primary Children's Hospital Center for Safe and Healthy Families, us, and request. But I strongly recommend not trying to bring all kids into primary. That's why we have the Children's Justice Center. And then they can counsel with you and go, okay, what are you suspecting? What are you seeing? Okay, this looks like this needs a medical, or it may not. So, did you have something to add to
I was
that?
just pointing that, our nursing intake line is a great place to call, because then our nurse can help talk through the family.
For here in this area, but also in satellite locations, I really recommend checking directly with your Children's Justice Center too.
So is that the same number? So earlier you were talking about a line for physicians to call if they're questionable.
If a physician has a question like that, they can call either the nurse intake line during business hours, but on this brochure, there is a number that talks about, for urgent assistance after hours, weekends, holidays, please call the Primary Children's Hospital and ask to speak to the medical provider on call for physical abuse or sexual abuse. So, but usually, just checking with our nurse intake during regular business hours, which I'm assuming most of the doctors you work with, that would be when it happens. She will help screen, and everything we do, our nursing staff will circle back and check with the prescriber. So the provider, either a child abuse pediatrician with us or a registered nurse practitioner. The registered nurse will check with the nurse practitioner in the Children's Justice Center. Okay? Yes.
So, in making referrals, I just wanted to get some clarification. It's appropriate to refer to you up at primaries if it's an acute. Within what time frame?
Within 5 days.
Within 5 days, because they need a medical exam.
Right. But you can also depend. I don't know if most of you in this room are here in Salt Lake County. Okay. No.
Utah County.
Utah County. So they have a Children's Justice Center there. You can also call and get guidance again from the nursing intake.
So is that really what you would prefer, from someone like in Utah County, is that we're going through the CJC and not to you?
It's your discretion. Absolutely.
Okay.
And Primary Children's Hospital will do the 24-hour acute sexual assaults examinations. And
like up through the ER.
Yeah, but we don't want people just showing up to the ER, because sometimes people will show up to the ER and it's been 7 days, or it's a prepubescent child and they have less crevices. Things don't last that long. So it's maybe 3 days for a prepubescent child. Our medical staff that knows these things, and depending also on the type of contact. So our medical staff have all the knowledge and training to be able to guide you, rather than having a family come up and then us not knowing they're there, and then we have to do the triage in the emergency department. We can triage while they're sitting out in Riverton, and then we can say, okay, come up, and we will have someone there to meet with them. So and one of the cool things is we now have on-call medical social work as well that goes in with our teams for the acute sexual assaults after hours and weekends.
And that's not a telemed. They show up.
Oh, yeah. No, there are just certain things you can't do over video.
Thank you. Yeah.
Yeah. No, we do call in. Like if someone just shows up at the ED, we call and talk to them about the time frame and the type of contact. And then we make the medical decision. And if so, we're there by 30 minutes.
So if what's being reported in clinic is more historical, I'm worried about this. I really don't have a clear time frame. My child's just now mentioning this to me.
Which is
that's
frequent.
That's by far more common for us. CJC is that.
CJC, if that's who's in your area, or again, we do our clinic. We do flip back to the numbers page early at the beginning. Our clinic does a couple hundred of those a year, and that's in partnership with the Avenues Children's Justice Center. They're the same with the South Valley, and so sometimes if South Valley's backed up or we're backed up, we can share resources. All right. Now, one of the other questions that we got was work reporting to DCFS, and so we are so fortunate, and I've told you the 2 roles that Kari already has, but she was also a former DCFS employee, so we're going to turn the rest of the time over to Kari for her to share her great knowledge. Because one of the important things when in keeping children safe is our partnership with law enforcement and child welfare.
Yes. Hi. So, just to give you a little bit of background about who I am, I did an internship. Actually, my very first job in this child welfare field was with the youth services, the girls, what was it called? Girls Group Shelter. They did not have a Christmas box house shelter yet. And so, Girls Group Home. Is that what it was called? Anyway, and so because they didn't have a Christmas box house yet, we would get infants all the way up to 18-year-old girls and some young boys, because if the boy was too young to go to the boys group home. And that was my internship. And then from there, I worked for the Division of Child and Family Services. I did 3 different roles with them. One was on the child abuse hotline, which gave me a great overview of the types of calls they get, the types of concerns people call in about. And it also gave me an overview of the services available for people calling in. And then I became a caseworker, and they were doing a pilot program where they wanted to train caseworkers to not only do the investigations, but also become the foster care worker. So that gave me an opportunity to really hone my skills on forming relationships with families, because I might be the worker removing their children, and then I would still be their caseworker, which was really interesting. And then lastly, I took a role with that was hospital-based, where I was called the DCFS liaison, based in Primary Children's Hospital. And that's really when I started working with this team. It's nearly 20 years ago. And my job was to be there as a resource for the hospital when they had questions about DCFS or cases where there was suspicion of abuse. And it was a really great collaboration, and I started to learn so much and was very interested in that medical aspect of child abuse, the more severe cases. And so when an opportunity came to work with the team, I took that opportunity and became a social worker with the Safe and Healthy Families team. And my DCFS experience was incredibly valuable. I use it every day, and of course it's becoming more and more distant in terms of my direct experience, but I do still talk to caseworkers and supervisors and the intake hotline nearly daily. And so I have a sense of how their system works, or sometimes doesn't work, or changes that are happening. And that's all influenced by our Utah state laws. I mean, they follow a practice guideline handbook, and that's based on Utah statute. And so I have both a deep frustration and empathy for DCFS, because I know their jobs are hard, and I know sometimes their training is maybe not fully sufficient, and they're just like Dinah said, hearing you guys talk today about the types of cases you deal with, that's similar to the types of problems they're dealing with, and then layer on top of that an abuse allegation that they're supposed to sort out, because they go see a family and they just find there's one need after another that this family has. And so they've got a really tough job. And I definitely empathize with that when I speak to them. And then, like I said, the frustration comes when sometimes I feel like the communication is breaking down. And that's an important piece to me, is keeping that relationship with the caseworkers that I work with. So I get the sense in just hearing you all talk that many of you probably have made reports to DCFS. You've reported abuse and neglect, and okay. And there are some of you who have not had that experience yet? You've pretty much all, okay. So I think we can probably breeze through these, because I consider this quite an overview, a pretty simplistic overview actually. And then with whatever time we have, we can get a little deeper into maybe some questions that you have, even based on direct experiences. So what I always like to present to people is what our Utah Division of Child and Family Services considers the abuse categories, so that as you're meeting with your patients and families, you have a sense of what types of things are reportable in this state. So if we want to go to that next one. Maybe nothing on this list is surprising to you. Does everyone understand the child endangerment piece? Basically putting a child in an unsafe situation. Being around drugs is considered the environmental neglect, I believe. So sometimes that one's a little confusing. There's a little bit of overlap. And then, as Dinah mentioned, the forms of medical neglect, I believe the division still refers to it as pediatric condition falsification. We use the term medical child abuse. And then that last category, dependency, is in its own category. That's something that DCFS might determine where it was really no fault of the parent, but they are unable to care for the child. And that would still prompt an open case. All right. And then these are some ways I try to help people think through, because sometimes it can feel frustrating when you call and you have a concern. But again, they are going based on their practice guidelines, which are based on law. And so there's just some things that don't meet their criteria to investigate. And those things would be, immoral or illegal behavior by the parent. Sometimes it's challenging when we're meeting with a family and the parent is doing things that are dysfunctional for their family. They don't work well for their family. But when you really take a step back and look at it, it's their own lifestyle choice or behavior choice. We can't always point to a direct effect it's having on the child in an abusive way or neglectful way. Messy houses and poor hygiene of a child. If you're reporting that, you would just have to demonstrate the risk, point to what the risk is. The threshold for a home is pretty low. Is that the word? It'd be low threshold. No, high threshold. Anyway, I mean, when I worked on the hotline, people would call sometimes and say, there's piled laundry on the couch and the sink is full of dishes. And they wanted to report that. And I thought, you've just described how I left my house this morning. So it's very subjective, like everyone's idea of what's messy. And so when working on the hotline, I always had to have the person describe what is it you saw in the home to understand. And so you guys might not have, I don't know, does anyone do home visits? Okay, so you do. Yes. So they would want you to describe what you saw. And again, always just trying to assess what the risk is to the child. A child being out of control, is I'm sure you guys well know, is sort of a different division. It's more the juvenile services division. It's not a child protection issue unless there's more to that story that can be pointed to. And then child left home alone, that one gets asked a lot. There is no Utah law about what age a child can be left alone. And so the hotline will always ask you questions about that you might not have answers to, but do you know how long the child is alone? How does the child feel about being left alone? Do they know who to call? Are they asked to care for younger children? Are they asked to cook meals? Are they, try to find out a little bit more to understand how it is for that child. because, again, we all know, you think of the range of children you've interacted with, and some would be capable of being left home alone, and others just no. So again, it's kind of subjective. And then the difficult when child acts like they've been abused. There's times we just interact with kids and we have that gut feeling or sense that something's wrong, and that won't be enough for them to open a case. We have a lot of usually moms who call us and have that gut sense about their young 2-year-old child that she's been abused in some way or he's been abused, and they really can't point to anything specific, and it's hard. It's hard to reassure them, and we use this booklet a lot to give them an opportunity to open that conversation with their child in an open-ended way and begin to teach their child that it's okay to talk about those things or report those things if an adult is not treating them in the way this book describes. This book helps set up an expectation for kids of how adults should interact with them so that they learn that. Yes.
So how about for other children?
Children abusing children.
Yeah.
Yeah, so do you have a specific example?
Well, like if they're I don't know, there could be like a teenager for a toddler or two kids that are the same age, or, I mean, how do you identify and teach your child? Sometimes it's not always the parent or...
Oh, right. Okay, yes. Good.
Identifying for the families that you're working with or children that it's not always
an adult. Right. So this booklet, while I think it does sort of use adult examples of, like, I think there's grandpa and something, what I really like about this booklet is it teaches kids where their private parts are, for starters, and it helps differentiate, because little boys and little girls' bodies look pretty similar, especially up top. And so by telling them it's what your bathing suit covers, that helps little girls understand that their body is different from a boy's in that way. And it really just teaches kids that they get to say what kind of touches they're comfortable with from anyone. And then the thing I tell parents that's important to reinforce once you've read this book to them is that means no more telling Johnny or Susie, you have to go give Uncle Bob a hug on the way out. Or, give loves and kisses. And parents just sort of naturally do that, and it helps reframe that for the parent too, because we really are trying to empower children that their body is theirs and they get to say what happens to it. And that goes for, peers, older kids, babysitters who are around them. Yeah, so absolutely, if kids are making disclosures that way, that needs to be looked into. And when you call the hotline, sometimes they do have a difficult decision to make. If it's two children of a close age, 5 and 3, and it seemed to be mutual curiosity, they might not open that case. Even if one parent is really upset about what happened, they have to take all the information they're given and make the best decision they can. And they usually do that in a team approach. I very often have caseworkers say, okay, I'll go talk to, or like intake workers say, I'll go talk to my supervisor about that to make a decision about whether to open. Did that answer the question? Okay. Yeah. Okay. So what should you do? We can go on to the next one. And so maybe you guys are already doing this, and this sort of leans a little more toward physical abuse. But again, if a child has made some sort of strange statement about, Daddy touched my private parts when we were in the shower together, sometimes we're just taken aback because we're thrown off. Or a kid, as adults, I think it's quite natural when we see a kid with a little owie. It's even a building rapport thing, like, oh, what happened? How did you get that owie? But suddenly when they have a handprint on their face, we clam up and we get all nervous about we don't know what we're supposed to do. And so I just encourage people, do what you would always do with curiosity of children. Oh, tell me more about that. Daddy touching you in the shower on your private parts. Tell me more. Or actually, that in that case, that's probably enough right there to just report. But if you see a mark on a child, as best you can, sort of gauge your own reaction that's happening internally, but remain calm on the outside and just interact with them as you normally would. oh, how did you get that owie on your face? And see what they say. And then, oh, tell me more about that. And then what happened? And if they've said enough that you see now you can report that, just say, thank you for telling me about that. Thanks for telling me what happened. And just kind of leave it at that. Don't try to say anything more about what you're, necessarily what you're going to do next, or how, reassure them everything's going to be okay, because we don't really know that. You just know at that point you would need to make a report. So always, of course, leaving the questions open-ended and allowing the child to just tell it in a more narrative form. Go ahead. And again, I would get the sense you guys are quite comfortable talking with children, but it is strange when we're in that territory that we're less familiar with and abuse comes up, we can get a little more tongue-tied. And so just some key things, getting down to the child's level, sitting down with them rather than standing over them, asking them, is it okay if I talk to you for a few minutes, letting them know you care about them, things like that to just help make the child feel comfortable. And is it on this slide? I think it's the next one. And this is where I was talking about some of these things kids are telling you might be upsetting for you. And so even just noticing the kind of reaction you're having internally and try to remain calm on the outside. It's also very important to believe the child, because the fact that they've chosen to tell you means they trust you. And I remember one of our doctors pointing out, sometimes kids won't tell again. If they've gotten a reaction from someone that they didn't feel believed, they won't tell anyone again. And so even if their story doesn't quite make sense or sounds too fantastic, or the parent and you just can't imagine this happened, in that moment they just need to be believed, and then we can sort out we can sort out the other stuff. Did I see a hand go up somewhere? Okay. Yeah. Okay, and then go to the next one. So on that slide, what I was pointing to is just when you've had that experience, you might know right then, I need to make a report to Child Protective Services. But I also wanted to offer, if you're not sure, you are welcome to contact our team. Even though I've worked there for as many years as I have, I still rely on my team. Cases are so complex in the way that you guys described about your own cases. Ours are just kind of dealing with a different subject matter, but they're so complex, and it's helpful to be able to say them out loud and get other perspectives and then make a decision as a team. And that way you feel supported when you're making difficult decisions as well. So just know that we're a resource for that, because obviously we deal with this every day. I don't know how often it comes up for you, but we're happy to help you think through or talk through a situation. And so there we are. Those are our 3 main social workers who would answer that social work line. And those are the things we do. We take calls from parents inquiring about therapy. We just sort of do phone consultation on cases, and we also schedule medical exams. Unless it needs to go through the nurse first. Our nurses do that. So this is the Utah law, and I like to highlight these pieces to really help simplify it. When we get all complicated in our head, that essentially any person, some states there's certain mandated reporters, but in Utah it's any person who has reason to believe. That's pretty broad. And so if you do that in good faith, you trying to think of a more eloquent way to say you don't get in trouble. I mean, you've covered yourself. This is the way I explain it to parents too. When we have to make a report, there is a Utah law. You've told me something, or if I have clients in therapy tell me something, you've told me something that has me concerned that you've experienced abuse or neglect or whatever it is, and I need to report that. I need to get help from another agency.
Was there a question that we should follow up on Allison had?
Just to make sure the person who has seen and examined a child is who should be calling, right? So she's asking, just to make sure the person who has seen and examined a child is the person who should be calling. I have had doctors ask me to call on their behalf, and I'm not always comfortable doing so.
That's a very good point. So I think the strongest preference is always whoever has the most direct knowledge. So if the child disclosed to someone, ideally that person should call. Sometimes a child will disclose to a parent, and then the parent comes in and tells you, and they want you to make the call. I try to encourage that parent to make the report, but if I have concerns that they won't, I will make the report because I know it has to be made. And then in that case, what sometimes happens in the hospital is the doctors will prefer, because of the length of time it can take to make that report, it can sometimes be a 15 or 20 minute call if you have a new intake worker on the line. So sometimes they will ask that social work or some other supportive role make the report, which I suppose is okay, as long as that person feels like they have a clear understanding of what the doctor is reporting. But I think it's really important to put the doctor's name and contact number so that when it gets assigned to a caseworker, that caseworker can have a direct conversation with the provider.
And that doesn't delete the doctor's stewardship to make sure it happens.
That's right.
So you can say, yes, we will make this call, but remember, this is your license.
And I just thought of one other thing, and then I'll get to your question. I have had social workers in the hospital say they are uncomfortable, and I have suggested to them a couple of things they could do. They could just go back to their provider and say, I'm uncomfortable making that report. Or being in the supportive role that they are, they can go ahead and make the report, but make it clear that this is the doctor's opinion, and they are reporting that. Yeah.
Is there a time frame? Like if a child says, last year, or when I was 5 and now they're 10, or...
So at some point where it just cuts off and they won't do... legally, there might be in terms of what police can investigate. I'm not aware of that as being a real distinction with DCFS, so I tend to just always call and let them sort that out and make that decision.
The legalities are that disclosure happens at time of reporting. So if the child is barely reporting, then that is considered.
That's when the clock starts or whatever
of the incident.
Okay.
Because if you think about how traumatic that can be, you can remember things 30 years later. Even adults could disclose for the first time in counseling, and then that is when the clock starts ticking.
And I think they are changing laws about statute of limitations, especially on sexually assault.
because they don't.
Because of that.
There are statute of limitations that they won't it may happen and you can do it, but they won't prosecute it after so many years.
Yeah.
They can't prosecute after so many years.
Yeah. We had an experience with our 3-year-old granddaughter, and the most frustrating part was that the police department, the investigating detectives, no follow-up, no word, no phone call for more than 3 years. Now, they had moved out of state, but they had stayed in, my son and his family had moved out of state while all this was going on. But it wasn't until one of the detectives called and said, we found the perpetrator, this is what we know. Even though she had been getting counseling, my son got the counseling. And to be a father versus a mother, you also have to consider the way they look at things differently. Mm-hmm. But this little girl was so specific in what she described, and she was talking to me, and so not only am I a nurse, but I'm a grandma. Mm-hmm. And things went the way they needed to go, unfortunately, but 3 years with no contact, I don't think that's okay. Mm-hmm. Even a phone call that would have said, we're still working on this, we have some more evidence, and indeed there were 4 girls in this daycare that had issues, and all 4 stories were exactly the same. Wow. And we're talking about preschoolers. Mm-hmm. So I just think that communication is absolutely critical in how it's done and when it's done, because I did my part. My kids didn't want to do it. I did it. Mm-hmm. I started it. I didn't want to be involved, but no communication from the police
Yeah,
department to them.
that is very
for
frustrating.
3 years.
Yeah.
So I think when you talk about legality, it's got to be, it's got to be more spread out. It's got to be a two-way thing.
That there's two-way communication. I had a similar situation with a therapy client I was working with, and that the police in her mind weren't doing anything, honestly, was part of the trauma for her. And it was really hard to know how to work through that with her, because I similarly felt an injustice for her. Did you?
Just to let you know, it's 6 more minutes
Okay.
while the recording will be going. That's
Okay.
not to say you can't go a little bit beyond that. Anything you want, though, for someone to hear, just keep that in mind. But
Okay.
we can flex a little bit.
Yeah.
Okay.
Yeah, let's...
And can I just ask a follow-up question? Did you also have an interview at a Children's Justice Center?
In the state that they live in now,
Yes.
what would be equivalent? Yes.
The Children's Advocacy Center. Everywhere else calls
Yes.
it Children's Advocacy.
Yes.
But, okay, because they can also sometimes help navigate with law enforcement.
And they did, well, they didn't with the law enforcement, but they did with Primary Children's, the state of Utah's attorney.
General,
and all
okay.
of that. Yeah. Okay. Yeah. And it's, I mean, we all know we're pediatric people. It's the little clues, it's the little things that she was starting to say, and I said, that is not making good sense, but it was making sense to her.
Yeah.
You know, you've got, sorry, I thought you were still not.
No, it's okay.
But, yeah, sorry. But I mean, she was complaining of bees in her vagina, and that's how she described it.
Yeah.
And she also got multiple UTIs. And I started looking at the pattern and listening to what she said, and I called my son and said, I think we have a problem. Total denial, which I think is normal.
Right. Sure.
And it was probably good that he got a job out of state, because he just couldn't settle down until he got the call that said, we found the perpetrator, and it's taken care of.
Wow.
And because the evidence was so strong, they did not have to go to court with these little girls.
Oh, wow.
So that was a blessing. But
Yeah, long time coming,
long
but
time,
it ultimately...
long time. And he admitted he finally was able to let it go when he got the call that they had found the person.
Wow. This slide is just to highlight that you do not need to solve the case and find the evidence before you make the report. Again, just remember it's that reason to believe.
Just a really quick question. So if you are, let's say you're non-family, so not mom or dad or somebody, and you are reporting this, what right do you have to know any sort of the follow-up that happens? My sense would be you really aren't entitled to that. Is that correct?
You are not, other than... Yeah, you're not. I was going to say, please list your name and phone number so that if the caseworker has additional questions, I mean, you guys are a resource. I am clear about that now after being with you here today. I think you are more connected to the community resources than most caseworkers that I talk to, DCFS caseworkers. And so if you're willing, please make yourself available as a resource. But you're right, there's not always much they can tell you.
The reason I'm asking is we had a report on an adult case in our family. And when we tried to really fish a little bit more and find out, we were pretty much told, well, you made the report, but it's none of your business. We aren't going to give you any information on what we're doing or what the status of this is. So, you felt like you did the right thing, and it was kind of anticlimactic. But, I mean, ultimately, we had to live with it and say, okay, we reported this. Now it's up to protective services to, kind of...
And they are supposed to at least send you a letter at the conclusion saying something very vague and broad, like, we've closed it. Which at least tells you if something new happens, I now know to report again because they've closed. Yeah.
And sometimes it's the multitude of reports over time that also tips the scales.
I also like to put this one up. This is actually directly from DCFS's website because a lot of people have this concern. What if I report and it gets worse? And they point out that doing nothing virtually guarantees it'll continue. And so you're right. We can't guarantee that things will get all handled and tied with a bow. I think we're all clear about that, right? Anyone who's made a report to DCFS, you sometimes walk away with that sense that nothing happened. But actually, the next slide. This is also from their website. They reassure that if you report that some action always occurs, even if that action is simply documenting your concerns at this time, it potentially builds a record, sort of builds a case behind the scenes that the next person who calls they can start to say, oh, there are similar concerns coming from multiple areas. This now sort of meets our criteria that we can go out. So they do document that. There is the hotline. Does everyone have that quickly available? We should have maybe I have little handouts. I should have brought those. And we can skip that. These are the minimum criteria, very minimum. Actually, it does need to be a child under 18. As soon as they hit 18, it's adult protective services. You do have to have some sort of accurate address to locate the child. And then some sort of specific incident or pattern. Again, just not calling and saying that gut feeling. I just have that gut feeling something's wrong. I mean, you can call and tell them that, but they can't. They likely cannot act on that. They have 3 priority time frames, and they make that determination based on level of risk to the child and potential loss of evidence if there's physical marks or acute sexual assault. And go to the next one. We already discussed the Children's Justice Centers and their role. Caseworker has 30 days to do all of their assessment and make some kind of determination about the case. They can extend to 60 or 90 days, but they try not to do that. So again, just know they have about 30 days to do all the things they are supposed to do. And that can include reviewing records, talking to third parties, making home visits. All of that has to be at the consent of the parent.
Your meeting has ended.